Good morning, ladies and gentlemen, and welcome to this session. It's my great privilege and pleasure to welcome to the stage Dr. Mohammed Khair Hamad, consultant endocrinologist at Hamad Medical Corporation, which I know very well from my previous stint in Qatar at Cornell. And I'd welcome him to the stage to give the state-of-the-art lecture, Osteoporosis Update.
Assalamu alaikum, good morning. Again, this is the second lecture for today, but this is like different topic, so hopefully we'll enjoy together. So today I will talk about osteoporosis update. Sometimes it is difficult to discuss such a huge topic in a few minutes, but I'll try my best to make it brief and informative. No conflict of interest. The outlines today will talk about the definition, clinical manifestation, impact of osteoporosis, BMD and non-BMD factors, fracture risk assessment, intervention threshold, and pharmacologic therapy. So osteoporosis is like a skeletal disorder characterized by compromised bone strength and predisposing to an increased risk of a fracture. So it is about fracture risk. This is the most important thing. And it is a chronic condition. Why it is important to know that is chronic condition? Because we need to follow the patients like a chronic and to, from the beginning of the evaluation, to give them the idea about the disease, and they will not like be increase the compliance of the medication and the treatment. The bone strength is not only about bone density, it is also about bone quality, so both factors are important. Although the bone density is very important for the strength of the bone, but the quality also, it is extremely important as well. The World Health Organization for classification of osteopenia and osteoporosis in 1994, this is an operational definition. So this is like to epidemiologic definition rather than to guide the treatment and these things, but during the studies and the clinical trials, they were using to include the patients based on these definitions. So like low bone mass between -1 and -2.5, osteoporosis -2.5. I dig deeply to know why exactly they chose this number, but it seems a little bit an arbitrary, -2.5. But in the next few slides, I'll try to find a correlation between these numbers and the risk of fractures. And the severe osteoporosis like -2.5 with the fragility fracture. The low bone mass, and there is also microarchitecture disruption. So we can see here in the image, the structure of the bone here is more porous, and the trabeculae are thin and less connected together, and there is also microfractures here. And this is very important to give the strength of the bone. The pathophysiology and the determinants, it depends on the balance between the osteoblasts. We know that the osteoblasts and the osteocytes are very important also for the bone integrity, although it was considered previously that they are like dead osteoblast or embedded between the body, but they have like the spider-like structure or dendritic cells. They are sensing the pressure on the bone, and they are very important for the fixation or maintenance of the bone. The osteoclast also, although they are under the control of the osteoblast, but if there is over destruction of the bone from the osteoclast, and there is undersupply from the osteoblast, we end up with osteoporosis. And the remodeling process is very important. During every year, around 10% of the bone is laid down and removed to make a bone healthy. So it is not a dead tissue. So any disruption in the balance or any process that affects this balance will lead to osteoporosis. If we can see that our peak bone density achieved around in the 20s. It's not like in 40s or 60s or after cessation of the menstrual cycle. After that, men and women both, we are dropping the bone, but during the menopause, we have like around a sharp drop in the bone density. So if we have like any condition affect the bone from and we are not attaining a bone mineral density in the maximum, or if we have some condition that accelerate the loss of the bone, we are end up hitting the line to have osteoporosis. The clinical manifestation is of fragility fractures. What is the definition of fragility fracture? Is a spontaneous fracture from minor trauma. Usually, the trauma cannot cause a fracture in a normal person, like falling from standing height. It is important also in the clinic always to investigate what type of trauma. This doesn't mean that if a patient with osteoporosis will not, if have like a road traffic accident, will not get a fracture. But a normal person, even this minor trauma will not cause any fracture for him. But not every fracture or fragility fracture is related to osteoporosis, because we have to investigate for other causes like the pathology fracture, if there is any bone disease, bone cyst, bone tumors, metastasis to the bone, also make the bone susceptible to fracture. Usually the osteoporosis doesn't cause pain until there is a fracture. So a lot of patients, and we are receiving a lot of referrals because back pain, hip pain they have, and they were referred to evaluate for osteoporosis. And osteoporosis by itself cannot cause pain unless it's the fracture. That's why if we have like back pain, maybe it is related to fracture of the vertebrae. And with that, the height loss also, because of accumulated fractures and loss of the height of the vertebrae, will lead to height loss and sometimes kyphosis because of the change of the architecture of the vertebral column. Fragility fracture also can affect the spine, mostly the hip, and the most deleterious effect, wrist, also humerus. Rib fracture sometimes is not considered a fracture. Sometimes with elderly, they are more or less flexible, so they are easier, even with sneezing can get fracture, and the pelvic bone. And also sometimes there is a fracture, it is like stress fracture from repetitive trauma, especially in those with athletes. So it's not considered a fragility fracture. The burden of the fragility fracture is very important. So premature mortality, so we are talking about something can increase the mortality, so this is serious condition. The first year mortality is around 20%, and also increase in the first 5 years 3 to 4 times. So we are dealing with a deadly condition. Osteoporotic fracture is associated with subsequent fractures. So the first fracture will lead to other fracture. And this is very important to convince the patient why they should be treated from the beginning, and if they have any fracture, to prevent further fractures. And also decreasing quality of life, diminished physical function, reducing independence. And this is very important. There is like the thread between the dependence and independence is very short. And if there is any problem, the elderly, he will lose the independence. And this is very depressive and very also increase the burden on the community and on his family and on himself as well, or herself. So these are very important. Although with these things, still osteoporosis is undertreated as underdiagnosed as well. Worldwide, usually we are expecting like 6 million hip fractures in the year of 2050. Worldwide incidence around less than 100 to 600 according to the population per 100,000. In the GCC area, according to 250 to 300. Aging and the fracture is very important. It's not only about the weak bone. They have weaker bone. They have also imbalance, and they have tendency to fall. They have also visual impairment. They have a lot of medications can cause dizziness, cause problem with the balance. And they have also a problem with the cognition, and they have a problem with the evaluation of their risk assessment. Sometimes they are underestimate the risk. A lot of patients, they are climbing the ladder, or they are not evaluating, they are at risk to fall and they get fractures. That's why it is important to care about these patients from the primary to screen for them, then secondary to provide care for those who have osteoporosis and the tertiary to prevent further fractures and further comorbidities associated with the established fractures. That's why it is important for the diagnosis and the treatment. The clinical diagnosis of osteoporosis based on if we have a fragility fracture, BMD criteria, as we discussed in the WHO criteria, and the risk assessment criteria. Accordingly, we can see that the DICSA scan and the BMD, and this is a big topic, it takes like more than one lecture to discuss the DICSA scan, but usually we are having the two-dimension, so it is an aerial rather than volumetric, and from the lumbar spine and the hip and the neck, and we can see here according to the age, and we can accordingly correlate this with the population and measure the T-score and if Z-score in the population who are young and premenopausal. This is vertebral fracture assessment, like it is a lateral view. This is a patient who has normal BMD, but he has like wedging of the vertebrae, so he has osteoporotic fracture, and so he's fulfilling the criteria on diagnosis of osteoporosis. If we can look here at the lumbar spine, why we are the T-score is underestimating the problem, and because we can see that most of the fractures are happening in the population who are not in the osteoporosis range, but the rate of fracture, it is higher as the bone is or the T-score is lower. So we can see here in the -1 to -0.5, still we have a lot of fracture here in the osteopenic range. Is very high, and even in the osteopenia, the hip fracture, most of the cases are happening in this category. Even in the normal, we are still having osteoporosis. And if we can see here, the rate of a fracture is higher with lower T-score. That's why we have non-BMD factors to increase the sensitivity. So less patients are missed, and to improve treatment goals, because we are our aim is not improving numbers, our aim is improving the risk and decrease the risk of a fracture. That's why it is important to include also any factors that can affect the microarchitecture and the osteoporosis. Like fragility fracture can happen even if we have above the threshold in the osteopenic range or even in the normal range BMD, and that's why microarchitecture disruption is important to measure. So are we able to measure this? Yes. Either we can use the high-resolution peripheral quantitative computed tomography or MRI in the peripheral and assessment the trabecular bone microarchitecture. Also the disruption of this increase the fracture risk. Although this is like time-consuming, expensive, radiation exposure, and the cost is high, but still it is like a field used also in the research. That is important. That's why we have to make sure we have something, we can draw data from these things. It is called the trabecular bone score. If we can look here, we have this forest. There's like density is low of the trees, and it is also disrupted. But if we can look at these two, we have this dense trees, and here also we have dense trees, but the quality is not good. So this is the same concept of the TBS. The TBS will measure how connected the bone is, and accordingly, if we have degraded TBS, we have independent risk of a fracture. That in this we have, although the density is high, but the degraded quality make the bone is weaker. If we can see here that the BMD is a number, it is not like, and it is draw data from 3D to 2D dimension. We can see here two patients, they have the same bone mineral density, but here the TBS is lower, so they are at they are higher risk of a fracture. That's why it is the FRAX score was introduced in 2008 it puts the risk factors together, whatever is the BMD. It's the age, the gender, the BMI is important, and all the factor, previous fracture, parent hip, current and glucocorticoids, rheumatoid arthritis, secondary osteoporosis, and alcohol. In addition, we can also adjust it with the addition of the BMD data. Although there is some problems with the BMD because it is a lot of question is yes or no, and it is not dose dependent like in the glucocorticoid. The smoking, the previous smoker are not counted. The previous fracture, when the fracture happened, will not be counted. A lot of other risk factors are not counted in this version of the BMD. Is it important to have any idea about the recency of the osteoporotic fracture? Yes, it is a risk factor for a new fracture and higher risk in men and women at younger age. So if we are having fracture within 2 years, the risk is much higher than if the age of the fracture is more than 2 years. The glucocorticoid in the previous image showed that it is yes or no question, but we can also adjust according to the dose. So if we have more than 7.5 milligram and over 3 months, major osteoporotic fracture can be increased by 15% and the hip can be increased by 20%. Following history, we know that الوقاية خير من العلاج, and prevention is better than a cure, and tendency to fall increase the risk of a fracture, and the hazard ratio with increased numbers of falls. So this is also very important and not counted in the FRAX score. Also in the lumbar spine BMD, although the bone can be affected in the same direction and there is concordance between all the sites in the BMD measurement, but sometimes there is discrepancy and some diseases affect the lumbar spine more than the hip, and like hyperparathyroidism affect the cortical bone is more than the trabecular bone, and it can be measured in the peripheral DIXA. So also this can be adjusted accordingly by addition or decreasing by 10% for every discrepancy one between the lumbar spine and the BMD. Hip axis length also increase the hip axis length, increase the risk of a fracture, and diabetes mellitus and osteoporosis. It is even in the ADA guidelines, standards of care of diabetes, it is included since 2024, osteoporosis in diabetic patients, both patients type 1 and type 2 at increased risk, especially if they are young. Why diabetes and osteoporosis, microvascular, the same concept of HbA1c, the glycosylation products of the collagen in the bone make it less, the quality is less. The bone marrow environment and the fat cells in the bone marrow also make the milieux not suitable for bone synthesis, also the medications. That's why the type 1 they have decreased BMD, while type 2 they are having normal or increased BMD. And then how to make sure that we are not missing diabetes as a risk factor in the FRAX score. In type 1, if we have no BMD measurement, we can take yes for the secondary causes. In type 2, either increase the age by 10 or reducing 0.5 to T-score, or for rheumatoid arthritis, put yes, or using the TBS score. Is there any problem with the diabetes therapy and the osteoporosis? Yes, pioglitazone associated with increased risk of fracture. Women or more than men, usually more than 1 year of use. The mechanism is not very clear, but it is also related to the effect on the bone synthesis and the degradation. The canagliflozin also in a few secondary analysis showed there is increased risk of fracture as early as 12 weeks. So maybe the mechanism is related to the hypotension and the dizziness, but also it can be related to the phosphorus metabolism, fibroblast growth factor 23, and vitamin D metabolism. Although in the meta-analysis and systematic review, it didn't show it is associated with other, like the dapagliflozin or the empagliflozin. The GLP-1 in the rodent and the human cells, it is showing there is a protective effect on the bone, but because of the weight loss, it was associated with decrease in the BMD in patients who are receiving this for weight loss, and the effect can be decreased by the exercise. It minimizes the effect of osteoporosis. That's why we have to look at the osteoporosis as different. It's not a BMD, it is a fracture risk. That's why the new version of the Frax is released. It is called the Frax Plus, and now it is available and can be the same as before, and also can be integrated the other, like the adjusted for recent fracture, adjusted for the dose of glucocorticoids, the TBS, the duration of diabetes, the number of the folds, and if there is any discrepancy between the lumbar spine and hip. So we are trying to integrate more risk factors to make the either increase the risk or decrease the risk for every patient. Now, if we can look at this, the age is the most important factor. If we can look at this 65, if we can see that at 65, here in the hip, 65, if we have a line around the 3% hip fracture risk, it is around correlating with the 2.5. Maybe this is the draw between this and why it is related to some thresholds as 3% hip fracs for the hip and 20% for the hip, for the major osteoporotic fracture. So it's not very convincing why we are choosing certain numbers to treat patients, and if we have a patient with a Frax is 2.9 is not candidate for a treatment. That's why we have something called the intervention threshold. When to start the treatment. Is it fixed? Is it age-dependent threshold, or it is hybrid threshold? The fixed threshold we have, regardless of the age, if we are reaching the Frax like 3% or 20%, for major osteoporotic fracture, we have to intervene. The BMD criteria, so if we have minus 2.5 and low, so they are requiring treatment. These usually, according to the economic analysis, is not related to the patient or the prevention. It is economic factors affecting these thresholds. That's why it is important. Not every size fits all, and that's why a lot of guidelines now, country-specific guidelines, they are age-dependent. So everyone, according to the age, we are measuring the threshold to when to intervene for those patients. Because to have a risk for a fracture 3% for a lady who's 55, you have to have multiple risk factors, and maybe she will have a fracture before we are getting all the risk factors. And we have the hybrid threshold like in UK and in Lebanon and in Qatar as well. Accordingly, we can see here, if we have a prior fracture probability adjust for recency if appropriate. If we have low risk, then we have to treat. High risk, we have to treat. Very high risk, all patients, they need treatment. But here, if we have a fracture probability from the beginning in the clinic, we have to do screening. Like if we have low risk, just advice for lifestyle modification. Intermediate, in this zone, we need more information to either to increase the risk or decrease the risk. That's why we need BMD data. Accordingly, we can also re-establish the risk and to determine the treatment. Here, the same thing, we have no treatment if we have in the green zone, if we have no BMD measurement. So BMD is not only for like 65 of age. Sometimes we can use for any patient above 50, and accordingly we can see the Frax score. Accordingly, we can measure the risk of a fracture, and if we need to have more data, we need to obtain a BMD, especially if we are planning to start a treatment to monitor our treatment. Here, this is a diagnosis and management of osteoporosis in postmenopausal women in Gulf Cooperation Council countries. This is published in 2020. And here, the data also from Qatar, we have our own guidelines, and also it is connected to the FRAX website. So whenever we are measuring the FRAX, we can click on the guidelines, and accordingly, we can choose which area is our patient and their risk, and accordingly, we can tailor the management. And it was published in 2024, and it is now active on the system. Accordingly, we have to see the pharmacologic option, either to promote bone formation or to block the bone breakdown. And very important, before considering any treatment, to see if there is any fracture data. Like some medication, it has no efficacy on the fracture, so it is important to know which medication with the fracture improvement, not only it will improve the BMD or without any data on the fracture. And this is the ACE 2020 guidelines in the postmenopausal osteoporosis. After evaluation of the osteoporosis, correct the vitamin D, lifestyle modification, falling prevention, and these things. And accordingly, we can categorize the patient and start either anti-resorptive medication like denosumab, bisphosphonate, or the anabolic agents like the abaloparatide or teriparatide or the new romosozumab. And also here, it is the same thing for the endocrine society guidelines. We have to risk stratify our patients. If we have very high risk patients, like they have multiple fractures, or they have tendency to fall, or they have elderly, then we will consider like faster medication to act like romosozumab or the anabolic agent if they don't have contraindication. And then if no, accordingly we can decide which treatment should be tailored for them. The future trends in the risk assessment and the FRAX score, it can increase other risk factors like the hormone deprivation therapy, cancer survivors, if the patient has Parkinsonism and they have risk of fracture, so can be integrated more so we can have accurate risk assessment. Like the diagnostic modalities for the assessment of the microarchitecture, also sometimes use the ultrasound as impedance for measuring the bone density, and it is also important to the role of the serum markers like the bone degradation markers and also the therapeutic intervention. And yesterday there was some discussion about the stem cell, and this is also the future for stem cell in the treatment of osteoporosis. I remember one patient, she told me that the dates is the nails of the bone, like tamar huwa masamir al-azm. So there is a few like animal studies about the use of the dates in the improving the bone density, and it showed there is positive. Maybe we are in the Gulf area and we are consuming dates, and this is part of our nutrition. So it may have effect on the bone health in this area in the world. Osteoporosis is a major health problem, but still underdiagnosed and undertreated. BMD is correlating with the fracture risk, but is not the whole story. Fracture prevention is our aim in the treatment rather than treating numbers, and intervention threshold and risk stratification to tailor the management of osteoporosis. Thank you very much.
Thank you very much, Dr. Ahmed. Really a very nice lectures, not rewarding. But you understand that the osteoporosis almost second or the first hazard disease, in the whole world, and especially in the Gulf area, because as you see that vitamin D is very low in this population. Activity is very low. The size of the people are small. So all the things, it seems to be against them, And Of course, the treatment itself has a lot of hazardous, no doubt, you know, huh? And it seems to be it's non-starter, okay? And the only thing which people they suggested at the end is activity, okay, to antagonize the osteoporosis. So recently in Japan, they reached discover something where they block some of the enzymes in the teeth and not in the bone itself, okay? And it seemed to be that spur or increase the bone formation, okay? And to the extent that it probably it's extending to the same shape and numbers, you know? Probably you heard about this, you know, huh? Yeah. The question, do you see any future, especially we are really stuck in osteoporosis treatment? Thank you.
As I mentioned, still we are limited with the medication, especially you said about the side effects of the medication. But this is not justification not to start the treatment, because prevention of fracture is around, the efficacy of treatment around 50 to reaching 70%. But our fear from the medication is not justifiable not to start a treatment, like 1 in 10,000 for the atypical fracture in chronic use and the bisphosphonate, or 1 in 100,000 for the osteonecrosis of the jaw. I have a lot of patients, they are refusing the treatment based on this. But when I considering the risk assessment and showing them the numbers, they are convinced and comparing between the risk and the numbers. As you said, also the future is open for a lot of intervention, like the stem cell is still a lot of enzyme also involved in the balance between the osteoblast and the osteoclast.
Dr. Mohammed, could you make a quick?
Yeah. And also for the exercise is also stimulating the osteoclast. That's why we are increasing the activity of the osteoblast. Thank you very much.
One final quick question, but a quick answer, please.
Okay. You mentioned that some diabetic medications treated with osteoporosis and fracture. Do you recommend screening for osteoporosis before starting the medication?
Usually, a screening for osteoporosis, as I mentioned, for every patient for coming to the clinic. But if we are having a high risk of a fracture or they have osteoporosis, I'm trying to avoid using these medications.
Okay.
Lovely.
And one last question.
No, I'm sorry, we've run out of time. Thank you very much indeed, Dr. Mohammed.